Yeah, I mean, biomarkers for immunotherapy is a work in progress. Right now, I think the validated targets are obviously HER2, VEGF, and now checkpoint inhibition. Right now, the most reliable biomarkers that we have, MSI high status, is across solid tumors, is predictive of substantial benefit for anti-PD-1 and anti-PD-L1 therapy, and actually there's regulatory approval for anti-PD-1 therapy and chemotherapy refractory MSI high tumors, given the high degree of efficacy and durability of response in those patients. The next best biomarker that we have now is PD-L1 status. It does appear, it's not a robust biomarker, but it does seem to discriminate at a 1% and probably even better, a 10% or higher degree of expression, that we do see a stronger signal of activity for these drugs in metastatic disease. We're always looking for new biomarkers, and there may be different immunotherapy agents that there's some interest in major histocompatibility antigens as potentially predictive of a benefit of alternative immunotherapy agents, and it's really a work in progress. Does tumor mutational burden play a role? There was an interesting paper recently about MUC gene mutation in gastric cancer that seemed to be correlating with mutational burden as well as potentially a prognostic marker. So it's a work in progress. Right now, I think MSI high status clearly, unequivocally, the biomarker of choice to predict benefit for these drugs. PD-L1 status, regulatory approval in the U.S. based on PD-L1 positivity in refractory gastric cancer, and certainly seems to correlate. The higher the CPS score, the greater benefit. Whether or not we'll see that translate into the first-line studies, does CPS score identify patients that might benefit from earlier use of these drugs, it remains to be seen.